Hi friends, in this series of respiratory system examination, today I will talk about chest pain. Chest pain uh, I have already a video on chest pain or acute coronary syndrome in my emergency video section. You can see there also. Uh, Before starting the description about chest pain, first is the disclaimer. Caring Talks YouTube channel does not provide medical advice. Information available on this channel does not offer diagnosis or advice regarding the treatment. Information provided by this channel is for educational purpose only. It should not be used as an alternative to healthcare professionals' diagnosis or treatment of any person or animal. Please seek the help of medical expert for diagnosis, prevention, and treatment of medical illnesses. There is no endorsement for any brand or a company. If we describe chest pain, it is a dull, aching pain in the thorax. It can be cardiac or non cardiac. It has been seen that most of the cases, about 42% of the chest pain which present to emergency department, they are gastrointestinal. Ischemic heart disease related chest pain are only 31% and 28% are chest wall syndrome. 4% is contributed by the pericarditis, 2% by the pleuritis, pulmonary embolism, 1.5% cases are of lung cancer, 1% case of aortic aneurysm, aortic stenosis, and herpes zoster. So most of the cases of the chest pain who report to emergency department are gastrointestinal. The causes of chest pain can be categorized as cardiac, pulmonary or respiratory, gastrointestinal, musculoskeletal, and psychogenic. Among the cardiac cases or causes, the important causes are vascular, valvular, and related to heart. The vascular causes are acute coronary syndrome, stable angina, aortic dissection, aortic aneurysm. Valvular causes are aortic stenosis, mitral valve prolapse, and the disease of heart are pericarditis, myocarditis, tocosubocardiomyopathy, and cardiac tamponade. The respiratory causes can be categorized as the diseases of pleura like pneumothorax, viral pleuritis, when the involvement of the pulmonary vessel is there, that is pulmonary embolism. Disease related to parenchyma or the bronchi, it is pneumonia, tuberculosis, bronchospasm, malignancy, asthma, and other causes are diaphragmatic hernia. The gastrointestinal causes are related to biliary tract cholangitis, cholecystitis, choledocholithiasis. The causes which are related to esophagus like esophagitis, esophageal spasm, achalasia, GERD, that is gastroesophageal reflux disease, esophageal impaction, and other causes like peptic ulcer disease and pancreatitis. The musculoskeletal causes are related to cartilage or joint, costochondritis, sternoclavicular arthritis, rheumatic diseases, osteoarthritis. The diseases related to bone like cervical disc, rib fracture, and among the psychogenic or neurogenic causes are panic disorder, anxiety disorder, somatoform disorder, cocaine abuse. The neurogenic causes are herpes zoster, neuropathic pain, thoracic radiculopathy, thoracic outlet syndrome, and prolapse disc. Friends, whenever the patient of chest pain comes to us, we can further categorize them as potentially life-threatening causes and commonly non-life-threatening causes. The potentially life-threatening causes are acute coronary syndrome, acute myocardial infarction, unstable angina, pulmonary embolism, aortic dissection, myocarditis, tension pneumothorax, pericarditis, Borham syndrome, perforated esophagus, and the gastrointestinal causes are perforated peptic ulcer, acute pancreatitis, acute cholecystitis. These are potentially life-threatening causes. And among non-life-threatening causes are related to GI like biliary colic, gastroesophageal reflux disease, pulmonary causes like pneumonia, pleurosis, costochondritis, myalgias, anxiety related to herpes zoster. These are non-life threatening causes. So we should always remember these. We should always remember the rule of 4-2-1. These are the emergent causes of chest pain which need emergency management. 4 means 4 related to heart, that is acute coronary syndrome, aortic dissection, pericarditis, pericardial effusion or cardiac tamponade. 2 related to lung like pulmonary embolism and pneumothorax, and 1 is the related to esophagus, that is esophageal perforation. So remember 4-2-1. These are the emergent causes of chest pain and need emergency management or active intervention. So whenever a patient of chest pain comes to us, we have to take proper history, do his physical examination, and do diagnostic evaluation, and further make the differential diagnosis and manage. So in the history we have a formula Socrates. We have to ask about pain, and the pain characteristics Socrates as his site, O is onset, C is character. I will be discussing in my next slide. We have to see whether it carries a red flag, whether there is any past medical history, what are the medication or drug history if he has. In physical examination we will monitor his pulse, blood pressure, respiratory rate, do CVS examination, respiratory system examination, abdominal examination, and based on the findings we will do ECG, some lab tests like troponin, D dimer, CPK, CPKMB, routine RFT, LFTs, X-ray, 2D echo if they are required, and especially in cases where we are suspecting pulmonary embolism we will do angiography, also CT angiography also. So Socrates, S is the site where is the pain, O is the onset, how and when did the pain starts, C is the character of the pain, R is the radiation, does the pain travel anywhere, A is the acuity. Acuity means how bad is the pain, means we have to categorize pain on the visual analog scale. Then the time course, any pattern or previous pain. E is the exaggerating or relieving factors, and S is the are there any associated symptoms or not. So this is the first in the history of pain we ask for site, where is the pain, whether it is retrosternal, interscapular, right lower anterior chest, epigastric region, left lower anterior chest, whether it is in arm, whether it is in shoulders. So these are the various causes which I have enumerated with respect to the site of the pain. You can see various causes have been mentioned. For example, if the patient comes to us with retrosternal pain, then we must think about it could be a myocardial ischemic pain, pericardial pain, esophageal pain, aortic dissection pain, mediastinal lesions, and pulmonary embolism. Similarly, we can see the other causes as well. Next is the O is the onset, how and when did the pain start. Whether patient has any anginal system developing gradually, anginal symptoms developing gradually over a few minutes, whether it has a sudden onset of ripping chest pain with radiation to the upper arm or the back, lower back. If there is sudden onset of ripping chest pain with radiation to upper or lower back, it is unlikely to be anginal and we should suspect of acute aortic syndrome. or acute aortic dissection. If the patient has a feeling of chest pain of few seconds duration, it is unlikely to be related to ischemic heart disease. So, if the sudden and instantaneous chest pain will be seen in conditions like pulmonary embolism and tension pneumothorax. So, the patients of pulmonary embolism may have history of DVT, obesity, pregnancy, prolonged immobilization, or congestive heart failure patients. So, tension pneumothorax can be spontaneous, can be open. So, next in Socrates is the character of the chest pain. Character of the chest pain can be patient can have pressure, tightness, heaviness, burning sensation. It is seen in angina, unstable angina, acute MI. When the pain is of sharp character, it is seen in pericarditis. Burning pain is seen in esophageal reflux, peptic ulcer disease, herpes zoster. Pressure oblique tightness, burning sensation can be seen in esophageal spasm. Pleuritic type of chest pain is in pulmonary embolism, pneumonia, pleuritis, spontaneous pneumothorax. Tearing, ripping pain is seen in aortic dissection. Aching pain, musculoskeletal disease, and pain may have a variable characters, and we should think of emotional or psychiatric conditions. This is a universal pain assessment tool, and based on the intensity of the pain, we can categorize it from 0, that is no pain, to worst pain possible, that is 10. Next is the radiation of the pain. We have to look whether the pain is radiating to upper chest, whether it is going to neck and jaw, whether it is going to substernal region, left arm. These substernal areas, epigastric region, both arms, inner aspect, neck and jaw, left shoulder. These are the various interscapular region. These are the various sites where the pain of the chest can radiate. Next is the acuity. How bad is the pain? Anginal pain usually lasts more than 2 minutes but less than 10 minutes. The quality is pressure sensation, tightness, squeezing type of pain. Patient may have heaviness, burning. It is usually located retrosternal, often with radiation to or isolated discomfort in the neck, jaw, shoulder, arms, frequently on left. It is precipitated by exertion, exposure to cold, psychogenic stress. Patient may have S4 gallop or mitral regurgitation murmur during pain. Unstable angina pain lasts for 10 to 20 minutes. It is similar to angina but often more severe. Location is similar to angina and associated features are similar to angina, but it occurs with low level of exertion even at rest. Acute MI pain, it is of variable intensity. It often lasts more than 30 minutes. It is similar to angina but often more severe. Location is similar to angina. It is not relieved by nitroglycerin, may be associated with evidence of heart failure or arrhythmias. Chest pain of aortic stenosis, patient will have recurrent episodes as described for angina. Quality is as described for angina and location will be as same as that of angina. So, but the patient will have late peaking systolic murmur radiating to carotid arteries. Pain of pericarditis lasts hours to days. It may be episodic. It is sharp, retrosternal towards the cardiac apex, may radiate to left shoulder. It may be relieved by sitting up or leaning forward, and we may hear the pericardial friction rub. Pain of aortic dissection, it has an abrupt onset, tearing or ripping in nature, knife-like. It is usually anterior chest, often radiates to back between the shoulder blades. It is associated with hypertension and or underlying connective tissue diseases like Marfan syndrome. Murmur of aortic insufficiency can be heard. Pericardial rub, pericardial tamponade, loss of pericardial pulses. Loss of peripheral pulses can be felt, can be seen. Patients of pulmonary embolism will have pleuritic type of chest pain. It will have abrupt onset. It may last several minutes to few hours. Usually the pain location is lateral side of the chest on the side of the embolism. Patient will have dyspnea, tachypnea, tachycardia and hypotension. Next is the time course. Any pattern or previous pain. Patients of acute coronary syndrome will have onset over minutes, substernal pain, radiation down either arm to the jaw. It is non-pleuritic type of pain. Patient will have pressure or tightness. Will have history of smoking, diabetes, hypertension or hyperlipidemia. Examination may be normal but may have S3 or high GAP or crackles if heart failure has developed. Chest X-ray is usually normal. They may have dynamic STT changes or they may be absent. If ECG is normal, we can do serial ECGs and troponin level. If troponin levels are elevated, ST segment is elevated, and patient has persistent chest pain, then we have to shift the patient to cath lab. The pain of pulmonary embolism, I have already discussed. Pleuritic sharp type of pain, onset over seconds or minutes. Patient will have history of recent hospitalization, immobilization or malignancy. May have evidence of DVT, right-sided S3 or right ventricular heave. If there is massive pulmonary embolism, chest X-ray usually normal. The ECG may show S1Q3T3 pattern in about 10% of the cases, but more important finding in cases of pulmonary embolism is sinus tachycardia. If the clinical suspicion is low, we can do D dimer. If the clinical suspicion is high, we and the D dimer is elevated, we will prefer to do CT angio. Pain of aortic dissection, it may occur over seconds, minutes. It is substernal or midline, radiate to back. A tearing type of pain, patient will have history of hypertension, smoking. Examination usually unremarkable. Brachial pressure may be unequal. Chest X-ray will show widened mediastinum. ECG may not have any specific finding. If the patient is stable, we can do CT angiogram. If the patient is unstable, we will do transesophageal echocardiography at bedside. The pain of pneumothorax is also occurs within few seconds. It lateralizes to one side. There is no specific radiation. Patient will have pleuritic sharp type of chest pain. Will have history of COPD, cystic fibrosis. On examination, we will have diminished or absent breath sounds on the affected side, and there may be hyperresonance on the on that side. Chest X-ray will show pneumothorax, and we can manage this case by putting a chest tube. And then we have come to the E, that is exacerbating, aggravating, and relieving factor. The the pain which improves with rest or in sitting position is myocardial ischemia. Relief with nitroglycerin, it could be myocardial ischemia and esophageal spasm. Weak patient gets relief at the same or greater level of exertion with symptom on minor exertion in the morning. It is warm-up angina. We cannot rule out myocardial ischemia. If the pain worsens few minutes after eating, it is postprandial angina because of redistribution of blood flow to splanchnic vasculature after eating. Pain may increase in intensity on change in position or movement of the upper extremities and neck. It is less likely to ischemia, more likely from the musculoskeletal causes. If the pain is worse in supine position, improves on sitting upright and leaning forward, it could be because of pericarditis. Pain gets worsened on eating certain foods, drinking alcohol, or in reclined position. It may be because of acid reflux. If the pain worsens over 60 to 90 minutes after meal, it is peptic ulcer disease. Their patient may have various associated symptoms with the chest pain also, and these chest pain, if the symptoms include sweating, shortness of breath, nausea, vomiting, pain, radiation to neck, jaw, one or both shoulder or arm. If the patient has history of dizziness or lightheadedness, fast irregular heartbeat, it may suggest features of heart attack or myocardial infarction. This is a hard score for chest pain patient in emergency department. We have categorized based on history, ECG, age, risk factor, and troponin. If we get score between 0 to 3, then there are chances of 2.5% MACE over next 6 weeks. If the score is 7 to 10, 7 to 10, if the score is 7 to 10, then there are chances that patient will have 72.7% chances of MACE over the next 6 weeks, and these patients require early invasive strategies. MACE is major adverse cardiac events like MI, stroke, any other cardiovascular insult. The red flags in the chest pain are if the patient has sudden onset chest pain, crushing, tearing type of chest pain. A patient has associated features like dyspnea, syncope, hemoptysis, hemodynamic instability, features of acute heart failure, radial delay or new murmur, and 4 is to 4 to 1 formula which I have already discussed. If these types of chest pains are present, then these patients require urgent medical or surgical management. The causes of chest pain I have already discussed. Among the cardiac causes, we have acute coronary syndrome, aortic dissection, pericarditis, myocarditis, aortic stenosis, arrhythmias, various signs and symptoms, their presentation, how to investigate them. I have already mentioned in these slides. Angina basically is a severe chest pain due to ischemia. This is angina pectoris because of lack of blood or oxygen supply to the affected heart muscle because of obstruction or spasm of the coronary arteries. It is caused by a coronary blood flow that is insufficient to meet the oxygen demand of the myocardium. So it could be a typical atypical non-cardiac type of angina. Typical is when it is substernal chest discomfort with characteristics, quality and duration. It is provoked by exertion or emotional stress, relieved by rest and nitroglycerin. Atypical when it meets two of the above criteria. Non-cardiac is meet one or none of the atypical or none of the typical anginal characteristics. Stable angina, we call it as when the patient feels chest pain on exertion and it is relieved by rest. Unstable is when it occurs on rest or minimal exertion with increasing frequency and severity. Decubitus angina is when it is when the patient has chest pain while lying down flat. Princemental angina is because of coronary artery spasm. Patient will have brief chest pain with self-resolving transient ST elevation and normal troponin levels. This is the picture which depicts that in unstable angina there is partial rupture of an artery and does not cause permanent damage to the heart. ST elevation MI patient will have classic heart attack because of extensive heart damage, extensive blockage of the blockage of the coronary is there. In non-ST elevation MI, patient will have little bit occlusion of the coronary arteries without much extensive damage to the heart. Patients of aortic dissections, we find that there is tear in tunica intima with blood dissecting through the tunica media. It is seen patients in about 0.3 to 2.95 per lakh population. The risk factors are hypertension, smoking, bicuspid aortic valve, coarctation of the aorta, connective tissue disorder, patients elderly, Marfan syndrome. Pain is retrosternal, sudden onset. Pain is severe, sharp, tearing. May have patient may present with syncope, limb weakness. BP, if we have to compare in both arms, there will be radial delay or radiofemoral delay. Patients of pericarditis will have retrosternal pain, pleuritic, worse with lying flat. It is relieved with sitting upright. He'll have history of recent time. My patient will have history of CKD, post-viral infection like Coxsackie, autoimmune disease like SLE can present with pericarditis. Examination findings will be pericardial friction rip, not diminished after stopping breathing. Best heard at the lower sternal edge, patient leaning forward. Pericardial effusion will have diminished pericardial rub, diminished heart sound, dull percussion below the angle of the scapula, that is Ewart sign. Patients of aortic stenosis, aortic regurgitation, pulmonary hypertension, hypertrophy, cardiopathy, cardiomyopathy must be excluded in this case, since these disorders may cause angina in the absence of coronary atherosclerosis. In ECG, we will have widespread concave ST elevation. No convex or horizontal ST elevation will be there. There will be ST elevation in lead 2 more than lead 3. Widespread PR depression will be there. We'll get no Q wave, ST depression and PR elevation in AVR or V1. No ST depression in any other lead other than AVR or V1. Spotic sign positive, that is down sloping of the TP segment will be there. Chest X-ray may show globular heart shaped. The vascular causes of chest pain are pulmonary embolism, the risk factor hypercoagulopathy, immobility, long hours of flight, recent major surgery, malignancy. We will do chest X-rays, color Doppler, limb vessels, ECG may show sinus tachycardia, S1Q3 T3 wave pattern, but this is less common. D-dimers are usually done to rule out pulmonary embolism. If it is positive, then we must do pulmonary angiography. If it is negative, then chances of pulmonary embolism are less. The respiratory causes of chest pains are pulmonary embolism, pneumothorax, pleurisy, COPD exacerbation, asthma exacerbation. How do they present? I have mentioned in these slides. Spontaneous pneumothorax will present as a pleuritic, sharp knife-like pain, continuous pain, aggravated by inspiration, sneezing, coughing. The risk factor may be COPD, old TB, connective tissue disorders. Chest X-ray will show features of pneumothorax, visible pleural line, area divide of vascular markings, mid-external shift. Patient of pneumonia will have fever, productive cough, pleuritic types of chest pain. Palpation may reveal increased tactile fremitus. Percussion node is dull, reflecting underlying consolidated lungs. Patient may show or have capitation. We will hear bronchial breath sounds. The gastrointestinal causes are gastroesophageal reflux disease, diffuse esophageal spasm, achalasia, Mallory-Weiss syndrome, esophageal perforation, peptic ulcer disease, cholecystitis, biliary colic, and pancreatitis. Muscular skeletal causes are Treat syndrome, intercostal muscle injury, epidemic myalgia. The pain is aching, variable intensity, vary with posture or movement of the upper body, can be accompanied by local tenderness over the rib or costocartilage. Patient of costochondritis, chest pain is aching type, aggravates with coughing, deep breathing, physical activity. Tenderness and palpation may be seen. Neurological causes of chest pain are prolapse, intervertebral disc, herpes zoster, thoracic outlet syndrome, cervical rib. Psychogenic causes are hypochondriasis, panic attack. Pleuritic chest pain is characterized by sudden, intense, sharp, stabbing, burning pain in the chest when inhaling or exhaling. It is exacerbated by deep breathing, coughing, sneezing, and laughing. When pleuritic inflammation occurs near the diaphragm, pain can be referred to the neck or the shoulder. Pleuritic chest pain is caused by inflammation of the parietal pleura and can be triggered by a variety of the causes. The causes are pulmonary embolism, myocardial infarction, pericarditis, aortic dissection, pneumonia, pneumothorax. How do we differentiate ischemic cardiac pain and non-cardiac pain? The ischemic cardiac pain will be central, diffuse, tight, squeezing, dull, constricting, choking. It may get precipitated by exertion, emotion. Radiation may be seen to the jaw, neck, shoulder. The relieving factor is rest in less than 5 minutes, nitrates. Associated patient may have breathlessness, diaphoresis. Non-cardiac pain will have peripheral location, or it will be localized, sharp, stabbing, aching type of pain. It may be spontaneous, not related to exertion, usually no radiation, not relieved by rest or nitrates, and associated features they depend on the cause. Types of angina I have already discussed. Here I will discuss about microvascular angina or cardiac syndrome X. When the patient has angina like chest pain in the context of normal epicardial coronary arteries on the angiography, we call it as a microvascular angina. Episodic angina is this syndrome is one in which pain having the characters of angina of effort occur at the longer or shorter interval. Nocturnal angina is seen in severe aortic regurgitation and proposed mechanism are prolonged diastole at the night and regurgitation time is prolonged. Dilated left ventricle, increased left ventricle mass, increased demand, diastolic coronary stealing, venturi effect of AR jet. Angina decubitus is angina when person is lying down and it is not necessary only at night without any apparent cause. Occurs because of gravity redistributes fluids in the body. Refractory angina that cannot be controlled with optimal medical therapy where revascularization is not feasible. Status anginosis is it is a clinical term denoting periods of frequently recurring anginal pain at rest indistinguishable from the pain of the cardiac infarction or from its proximal prodromal manifestation but without the electrocardiographic and laboratory evidence of classical cardiac infarction. Vincent angina is fusospirochetal infection of pharynx and palatine tonsil causing ulceromembranous pharyngitis and tonsillitis. Ludwig's angina is severe diffuse cellulitis that presents as an acute onset and spreads rapidly bilaterally affecting the submandibular, sublingual and submental spaces. Abdominal angina is postprandial pain that occurs in mesenteric vascular occlusive decidus. Angina sin dolor. It is a painless episode of coronary insufficiency. It is associated with diabetes mellitus and also called silent angina. Second wind or warm-up angina describes the patients with ischemic heart disease and exertional angina that forces them to stop after the first bout of angina and they are able to continue with minor or even without any further symptom. Ischemic preconditioning and collateral recruitment are proposed mechanism. Linked angina is when it is associated with gastroesophageal and duodenal disorders and diseases, gallbladder disease, cervical spondylitis. This is the Canadian Cardiovascular Society functional classification of angina. Class 1 is ordinary activity, for example, walking, climbing, stair at own pace, does not bring on angina. Angina occurs only with strenuous, rapid, and prolonged exertion at work or during recreation. Class 2 is slight limitation of ordinary activity. Symptom occurs when walking or climbing stairs rapidly, walking up a hill, walking upstairs after a meal, in cold weather, in wind, or when under emotional stress or few hours after walking and climbing more than one flight of the stair at normal pace and normal condition. Class 3 is marked limitation of the ordinary activity. Symptom occurs after walking 50 to 100 yards on the level or climbing more than one flight of ordinary stairs in normal condition. Class 4 is marked limitation of ordinary activity, inability to carry on any physical activity without discomfort. Angina may present at rest. Anginal equivalents are these are commonly seen in elderly and diabetic in patients with autonomic neuropathy where ischemic angina is absent and may present with shortness of breath, perspiration, diaphoresis, syncope, GI symptoms like upper abdominal pain, nausea and vomiting, fatigue and confusion. Other symptoms which I am discussing here are noisy breathing, or obstruction of the airway. It is seen in when it is seen at laryngeal level, it is called stridor. We get inspiratory sound. Oropharyngeal level, that is stutter. Tracheal level, it is rattling. Bronchial level, it is wheezing. These are the other symptoms which are related to the respiratory system examination. They are not linked with the chest pain. Because I am concluding the symptomatology in this video, that's why I have discussed them here. Hiccups, they are usually patient may have hiccups also. And the respiratory causes include basal pneumonia and pleurisy. Patient may have snoring, features of obstructive sleep apnea. Hoarseness of voice, causes are inflammatory like acute and chronic laryngitis. Smoke inhalation. Neoplastic causes are carcinoma, laryngeal papillomatosis, recurrent laryngeal nerve pulse damage, that is post-thyroid ectomy, carcinoma of the lung, breast. Neurological causes are myasthenia gravis, hypothyroidism, rheumatoid arthritis. There is involvement of crico-retinoid joint, habitual dysphonias, Rinke's dysphonia, Singer's nodules or vocal cord polyps, gastroesophageal reflux disease. Benjamin Spock has said, "Trust yourself. You know more than you just think you do." With this, my topic or video on chest pain is finished here, and this was all about the symptomatology in respiratory systems. In my next video will be on respiratory system examination. We will do the general examination, inspection, palpation, auscultation, and I will be apprising you people about these various examination steps in my next coming video. Thank you. Keep learning.